Welcome back and thank you for staying with us. This second hour we are focusing on health matters, especially tackling Africa's healthcare challenges. Joining us right now is Dr. Rosaline Ngugi, consultant physician as well, and the president of KDSG, chair of KAP Nairobi branch. Now there is an upcoming conference, an annual scientific conference that is tailored to theme fostering regional partnership for health innovation and research in Africa while highlighting non-communicable diseases, guidelines, patient care and conference expectations. Daktari, welcome to the set.
Thank you for having me.
And Daktari, before I get to the conference, we'll be getting to that. Let me start with this particular issue. Non-communicable diseases have been a major problem, not only in Kenya, but in the whole of Africa. So in terms of prioritizing this discussion in the upcoming conference, how do you expect not only the participants, but the stakeholders who are there to tackle this particular issue?
You know, for the longest time, the focus has only been on communicable diseases, specifically HIV and TB. And if you look at actually the expenditure has always been focused on that. Now, what is interesting is these people are living longer, the ones with HIV and TB, and they're now developing these non-communicable diseases, which are diabetes, hypertension, and cancer. Now, some of the things I can tell you, we had our conference earlier in the year for diabetes, and we realized in as much as we say the prevalence in Kenya is between 3.3 to 4.5, we think it's underestimated. Why? Because we are not screening, we're not focusing on prevention. The average Kenyan actually does not go for regular medical checks. Like I'd ask you, when was the last time you did your blood sugar or your blood pressure? I checked mine today. How many years has it been since you actually visited a hospital just for checkup? So what we are doing is first collecting data. Let's show the research. Because if I am not able to show a policy maker what the problem is on the ground, then we cannot be able to then influence policy on should we focus now, refocus our efforts, because what our patients are dying of is heart attacks and strokes in the background of diabetes and hypertension. And then the killer now is the obesity pandemic that is here with us, that has been driving all these non-communicable diseases. So what we need to put on the table is first recognize that one, it's a problem. Then number two, collect the data showing that it is a problem. Then now we refocus the efforts on a three-pronged approach. One, education. Number two is then prevention, by ensuring that you go and do your checkups. Then if you are diagnosed, ensure that you manage well and then prevent these complications. Then if you do develop the condition, then are our facilities equipped to actually manage this? And that's why you see us inviting Ministry of Health, so that they understand the problem that is there on the ground. And then we can then be able to address the issues that are there with us. That's the purpose of the conference. You know, when we talk about Kenya Association of Physicians, that's our umbrella body that looks at all the specialists in the country. That's your diabetologist, your cardiologist, your nephrologist, oncologist, all together. And they come together and we say, this is what we have found is a problem. We found lung cancer or breast cancer is on the rise. All right, so we need to screen for it more. We're finding diabetes in patients with cancer or hypertension, and can we then address these issues? So you'll find we'll share quite a bit of what we have in our specialties, and then we can be able to have dialogue about it.
And in terms of, given that at least you are here, and I'm sure you want to showcase those particular research in that particular conference, but what is the main factor that has led to where we are right now as a country and as a continent, especially when it comes to non-communicable diseases?
The number one problem is lack of education. We don't understand how big the problem is, because we've always assumed we are well, we are healthy, but we don't do checkups. So from the physician's point of view, we need to go out there and actually have more educational sessions. That's why you see I'm seated here, because I want to tell you, your grandmother seated in Turkana or Garissa does not know that if she starts peeing excessively, drinking lots of water, doesn't go for an eye checkup, will miss diabetes until it's very late and she requires an amputation. So number one we focus on is education. And that's why, as a society, we then formed the college called the Eastern, Central and Southern Africa College of Physicians, which I'll talk about a little later. Let's try and capacity build let me increase the number of specialists who can be able to diagnose and manage the condition. On the other side is we work with community health promoters and we give them, say, blood pressure machines and sugar monitors. People don't want to come to the health centers or the clinics. So how about we refocus our efforts and we send you your cousin who's a layman and we say we give you certain numbers. If this shows that it's high, send them now to the next level, a level 2 or 3 facility where someone can actually take them through that. Now, if you find one person who has a problem, say, with diabetes, then we screen the whole family. So we've caught 10 people in 1 week, which we ordinarily would have not until they presented later. Then the other one is, now we recognize that we have a problem. What are we going to do about it? Are our facilities equipped to actually handle these numbers? No, we treat malaria, typhoid. You see that's only being managed in the health centers. Yet what is killing people is actually hypertension. I went and did a medical camp, for example, in Voi. And the average blood pressure, normal should be about 120/80. Do you know the average blood pressure was 190/80? And they're perfectly stable and they're like, if it's not causing me pain,
yes,
why do I need to treat it? And that's when we realized education was key, but poverty is also a problem. So she says, do I buy food or do I take your medicine?
Yes.
But then if you don't take your medicine, that's how you collapse in your shamba and people wonder what happened to you. And so there's a lot of misdiagnosis. So what we are doing is trying to approach it from different levels. Work with Ministry of Health, work with relevant stakeholders, and then we come together and give you solutions. And this is what we do. We tell you that there's a pandemic of obesity, diabetes, hypertension, heart failure, cancer. And then tell you when you come just once a year, the amount of money I'll spend on just doing a random blood sugar, which is on average between 200 to 500 shillings, is the difference between you actually being managed as outpatient than being admitted in hospital, and then you spend millions of shillings. Because we've realized we are top heavy. You have a lot of people taking insurance, spending a lot of their money managing chronic kidney disease, heart failure, diabetes with complications, when these are people we should have caught 10 years earlier. We're saying diabetes is reversible for a certain period of time where you don't need medication. It just means a lifestyle change. I like the fact that you're seated there with a bottle of water. As opposed to you've had your cup of tea and you've probably had 10 of them with sugar in every cup. So when you look at that, you're actually reducing your risk. But what I want to ask you is, you've sat here from morning.
Yes.
Have you stood up to walk around? Have you, if you actually had a smartwatch like I do, it would actually tell you after 30 minutes, wake up, you've been sedentary. How much exercise do you do if you're here from 4 in the morning till late at night? When do you prioritize your health? And that's what we've realized. We have been sending the message of they come to see us when things are really bad. By the time you're coming to see Dr. Ngugi, the physician, then you know the GP wasn't able to manage you, or the clinical officer. That means there's a problem. And we are saying that work is too much up there. So and that's why we say, let's first train people, but at the same time, let me train the other cadres to understand the problem. Screen for them, look for them, because diseases don't come and say, a patient won't come and say, I have diabetes or hypertension. I have these symptoms. I've been feeling tired. I get headaches. And I don't know what it is. We check your blood pressure and we find it is high. And we ask you, did your mother or your grandmother or anyone else have high blood pressure? Is when you realize that yes, it's probably been there all along, you just didn't realize. And by treating one, you've treated a whole family, and then by extension, the in-laws. So can you imagine how many people you've managed just by screening? So that's why we're looking at it in different approaches. Looking at screening, then adequate management, and then from there, we are saying we can treat all these conditions in Kenya. You don't need to travel out of the country when we are ensuring that we are training specialists.
Okay.
And that's a mandate for the Kenya Association of Physicians.
That is very good that you've brought about that particular issue of Kenyans traveling abroad. But
Yes.
in terms of affordability, because you see the era we are in right now, not everybody can afford that insurance, SHA or any other private insurance.
Yes.
So in terms of ensuring there is affordability to address these concerns, as an institution, as a body, how have you addressed it?
So one of the things we look at is, are you involved with the technical working groups for Ministry of Health? When they call us to talk about, say, SHA, and its coverage for chronic diseases, for kidney transplant, for oncology, we make sure that we are involved in that. When you look at the Kenya Essentials medical list, and you look at the kind of drugs that are there, are we then insisting on originals only, or we are saying these generics can actually be useful? So we ensure, one, that we control also the test. You know that there is the, when you work with PPB and you also work with the medical labs, you have to ensure that they're actually managing, one, the costs. Because what you'll find, say, in Turkana is not what you'd find in Nairobi. The cost is also 10 times. So now we are sitting down with other stakeholders and saying that if it is in a public hospital, give packages. If I have, say, diabetes, and I want to come every 3 months, does that mean then that I will have to pay consultation the same amount, the test the same way? No, and that's why we are creating packages, and that's why you see even SHA has the packages for testing, for medication, so that we know it is covered, and it's not as you would if you have, say, malaria and you need just medication for 3 to 4 days. Okay? At the same time, we go and we sit down with the Ministry of Health and say, can we prioritize and address, when it goes to looking at the budget, how much money is coming towards health? How are you saying that this is the amount of money that goes to public institutions? This is the work that private institutions can do. And we want to, it's in such a way that, you see, when the idea of SHA came in, it was that you pay a little bit more so that your grandmother can be able to benefit. I mean, it has its issues, but those are the things we are looking at. How can we make medicines more affordable? How can we convince you, don't wait until you're so sick that you require so much money to the point where you need admission. If I tell you come once a year and we guarantee you will not be admitted for 10 years, isn't that a good compromise?
Yes.
That's what we are doing. Yes.
And in terms of, given that you're saying you're going to raise awareness in this particular conference, you're talking about even inculcating it to the hospital levels. You do know the first interaction for most Kenyans, it's down there. In their devolved units. So in terms of regional partnership, how has it been to further the cause that you're currently on?
So I'll give you an example of one of the projects. Because I'm the president of the Kenya Diabetes Study Group, I am privy to quite a number of the studies that are ongoing. So when we get grants, like, say, World Diabetes Foundation, and what we are doing is going to all the counties, and we get, like, of the counties, you get 2 or 3 facilities, and we encourage people to be screened and tested. And through that, we understand, one, we train people. Number 2, we educate the community, because we send community health promoters, and we ask them, do you understand what diabetes and hypertension and all are? Do you understand what these conditions are? Then number 2 is we go to the health facilities. What do you have? What are you capable of doing? And where do you think you need the assistance? Now, if you're able to prepare this report, then I can be able to come and inform you, this is our pain point. This is where I think we need to focus. Like, one of the issues was our doctors very well trained. So if we say we need a training, they come to Kenya Diabetes Study Group, I'll teach everything about diabetes. I'll work with the cardiologists and the Kenya Cardiac Society. We work together, and we've created modules for training online. That's why AI is amazing, because we have now telemedicine. COVID taught us do virtual sessions. And then we come and do appearances like this. And so one of the things we do is we have radio interviews, TV interviews. We go down to the village and we sit down with them 4 to 5 days, and we tell them, ask us anything you want. You've had relatives talk about diabetes. You've heard about use of herbal medication. What is the effect? So that we dispel the myths, tell them the facts, and then try and see. And then what you do is come back a year later and see the effect. Because one of the things we do is we sit in our offices, have these grand discussions, and then it doesn't go anywhere. And we never go back to see what was the effect of our intervention. So that is why the conference brings together all these collaborators. And they ask us, if we were to give you funds, what are you doing with the funds? And we say, in these, say, 47 counties, this is the issue we picked up. The majority are having diabetes, hypertension, refocus, instead of, say, antibiotics and all, make sure that essentials medicine list has medication for diabetes, hypertension, and then tackle obesity, simple things, nutrition and lifestyle. Yes.
And of course, in terms of ensuring that at the end of the day, the reason why we educate people, especially on non-communicable diseases, you do know there's stigma out there. At the end of the day, we do have our cultural beliefs. So how have you tackled it as an institution, especially ahead of this particular conference, in ensuring that stigmatization of individuals is reduced at least?
Can I tell you, it's interesting. You're more likely to get stigma over things like HIV and Mpox than you would about diabetes and hypertension. It's not like at a party you'll go and announce, it's only when someone collapses you discover, yes, they have diabetes. And I remember we went on live TV once and one of the patients said, you know why HIV is managed so well in Kenya? Is that they go to funerals, they go to weddings, they go to churches, supermarkets, and they talk openly about it. And so what we've done with each of our members is we go out of our way. Before, you'd never see us coming for interviews, doing podcasts and all. It is because we feel there's a gap, and information is key. So that if you want me to talk to my grandmother in Kikuyu, I'll get someone who speaks Kikuyu and we'll go on that radio interview. We'll go physically and do now runs where we go and actually talk to them on the ground at a level where we talk to them vernacular and talk to them about, these are the problems we are seeing, this is why a lot of your friends are dying, and this is how we are going to do. And so some of the things is translation of these items in English to one, Kiswahili, which is our national language. And then we're going a step further, and we actually go and talk to them now in vernacular. Now, converting the English to vernacular and publishing is where we have a bit of a problem because of funds and translators. But if we are to have this interview, say in Kiswahili, we could very easily switch, not now, obviously. Yes, thank you for that. But that's what we do. We try going down to the level. It's the same way. Majority of the people out there are geriatrics, the elderly. And we find that there are a group of people who've just been ignored. We focus on the children, which we focus on middle age, but we always forget about geriatrics. And those are the people who have the biggest problems. They're the ones who have the NCDs. So what we're saying is, even before retirement, we come to your offices. Like we'll come to KBC and say, can I just take a day and we talk about NCDs? So we are going to schools. We're going to universities. We are talking now on live TV, and we even come to your homes. And wherever that we talk, we are at all levels. If I teach, say, the GP will go and teach the clinical officer will teach the nurse, and the nurse is the one who we work closely. Because if we don't work as a team, you'll never be able to achieve that. That reducing that gap for information, because we have a lot of misinformation out there about these conditions. And I feel people take a very long time trying to manage them on their own, and that's where the problem lies. It doesn't mean you come to see me when you're sick. Come and ask me for my advice. You understand? Come and just do your blood pressure. Walk into any pharmacy and do a blood sugar. Ask them, what does this mean? And you'd see it actually makes a big difference. So that's what we've been doing on the ground.
And I'm sure this is something that will come up in the conference. You clearly stated that you have integrated with technology, especially with even AI. But how you are tackling that particular misinformation? Because you see, when I have a condition, instead of going to a doctor, the first place I'll run to is Google.
Internet.
Yes.
And you can't stop anyone. I mean, it's a free country. So what we say is that, you know, before when you'd come and see a doctor, you tell them the problem, and then they give you a prescription and you walk out. Now we are saying we're empowering the patient, the client, and say, if you have questions to ask us, we will answer back. Okay? There's a difference. I have spent 15 years getting to where I am. I think there's a difference between me and Google, isn't it? And remember, this is computer generated.
Yes.
It's not speaking to the individual. How a disease would present with me is different from how it would present to you, your sibling, and even your parents. And so one of the things we try and do as much as possible is we are also sending information. We are creating guidelines. Let me give an example. We sat together with stakeholders, both pharmaceutical collaborators, Ministry of Health, and came up with guidelines for diabetes, for hypertension. We are working on obesity guidelines, and we've got a booklet that we now then disseminate to the healthcare professionals. So wherever you are in the country, how I treat in Mombasa is how I treat in Nairobi. So we've sorted out the clinician. And now that clinician will give health talks in the offices and all. And now we are encouraging more of community projects. That's why you see the president had focused more on community health promoters.
Yes.
I train them the basics. Then if they need more information, then now you come to the hospital. One of the other things we say is, when you take your mother to hospital, you could be my patient in a few years. I make sure you come in. I educate you. You go and educate your friends, your colleagues at work,
Yes.
and also the rest of the family members. So it's little by little, a few steps here and there, but that is why we talk about this now. And you have segments where you have health talks, and now we are ready to do that for free. You call us any day of the week and say, I want you to tell us about what's coming. Not just, COVID taught us something.
Yes.
It taught us that we need to get out of our cocoons. It taught us that there's so much information out there that's misinformation, that I'll sit in my office in between patients, make a short video of 30 seconds and tell you, these are the symptoms of hypertension. These are the symptoms of obesity and its complications. Can you go and be tested? And so that's what we are doing in our own spaces. We're not afraid to go on social media. We are going to funerals. We are going to hospitals. When you're there in the waiting room, you will find in all the hospitals these little booklets that have all this information. Get tested. Now we are encouraging wellness packages. Let me give you an example. I work at Kenyatta University Teaching Referral Hospital. And now you have a wellness package. And what we are saying is, before you can come to see the specialist, why don't we do once a year? And you'll do a full body profile at only 40,000 shillings. But it covers every system, that by the time you're done, you know, I don't need to do this for another 2 years before I come back again. So if a public facility is able to do that, it means these services are available. The patients are just not being informed about it. So we do drives. And we tell you, can you come? We go into the community with the community health promoters. We use the chiefs, and we hear about someone who's been unwell. Can you come? We'll offer pro bono services so that people get managed. Yes.
Given that Kenya, we have made a lot of strides, especially within the health sector, and especially that sector that you're currently working in.
Yes.
In terms of drawing what other African countries are doing better than us, what can we draw from them? We can inculcate it within our system.
So I'm glad you mentioned that. So let me talk a little bit about our college. So Kenya Association of Physicians realized there was a deficit. We have a lot of GPs, we don't have enough specialists, and you can see that the universities are few and you need more specialists. So we combined forces with 6 other countries. That is Uganda, Tanzania, Zambia, Zimbabwe, Malawi, okay? And now we're even having other countries like Rwanda and South Sudan. And what we do is they teach our students, and through that we started doing research together. And we realized that some of our systems are better than theirs. Like, we have guidelines, other countries do not. Then, like recently we were talking to Botswana and Nigeria, and they were talking about what they have done to try and decompress, because you have more patients going to level 5 and level 6 and not the lower. And so we switched the pyramid, and we've said, can we empower these other cadres of healthcare practitioners? We train them, and we tell them, if you have basic diabetes, you can be treated in a level 2 or 3. That we learned. Let me tell you what South Africa does. South Africa comes, you come and you train, and then they create a hub for an NCD clinic, where it's a one-stop shop. you can be managed by one doctor for diabetes, hypertension, obesity, cardiac failure, and kidney failure. And then when they can't beyond that level, that is when they refer. So that I am left to see the difficult cases, and we then now bring. So what we did in ExaCop is we realized then you need to train, you have to come to Nairobi or you have to go to Eldoret, because it was University of Nairobi and Moi teaching referral. Now we say we have all these specialists, but they're not training their fellow specialists. So we've created a college where they train where they work. You come to KU and we are training students. You go to Mater Hospital, you go to Karen Hospital, Coast General, MTRH, and Joe TRH in Kisumu. Now we have those 6 hospitals training students for the 4 years. So what you do is someone is still taking care of the population while learning. When he's done, he enters into the system and he doesn't need to come and look for work in Nairobi. So now we're increasing the number of specialists out there, which is what we learned from South Africa. Now then you realize when you're talking to countries like Zambia and Zimbabwe, we have about, say, 350 to 400 physicians in Kenya. For a population of 52 million, that's a joke. It means we really need to churn out more specialists. But when you talk to other countries, you find they have 30 specialists or 50. So you realize as they come now for a conference, which is next week in Mombasa at the Pride Inn, you realize they are coming to learn from us. But then we realize there are some steps we jumped along the way which we can go back. Like we have newer drugs and we focus on prescribing the newer drugs. We forget that the older drugs can still be used, especially for people who need affordable medication. So sometimes we take a step back. You've seen recently a condition which we had eliminated called Mpox.
Yes.
Then we've had resurgence of it.
Yes.
We've learned the problem is every time we have newer drugs, antibiotics, we keep prescribing. Now the biggest problem we have is antimicrobial resistance. You go to hospital and you stay for 3 weeks because the doctor keeps on upping the medication, changing medication because of antimicrobial resistance. You're finding people dying of pneumonia where you ordinarily would not. And that's because now we have more diagnostic mechanisms, but the medication is not there. So we need to tell people step back. And we find some of the medications used in other countries, it's still functional. We stopped using it years ago. So we need to share. They're using, let me give you an example. We've started using AI in our facilities. Like Lions Hospital uses a fundus camera, okay? And you just look into it, it takes photographs. It tells you if diabetes has started affecting the eye. You take a photograph of a foot that's infected and you can tell the patient, this will heal in 3 months. Manage your expectations. And you can predict how it will progress. You'll say, this foot we can salvage, this one we cannot be able to. You understand?
Yes.
And then you have telemedicine. I'm seated in my office in Nairobi and you have very difficult cases in Garissa, but you don't have a diabetologist. So once a month, they collect all these cases, the doctor is there, and then they present the cases. You can be able to use, like KU, you have tele-ICU that you can project. This is the patient, this is how they look like, this is the current presentation, these are the current vitals, and what do we do? So we can be able to manage far-flung areas when we are here seated in the city center. That's how AI. So what we want to do is here, what is it that they're doing in the other countries? How are they incorporating it but not replacing? One of the studies I was involved in Thika, they got an algorithm of if you give a patient, say a 35-year-old with diabetes, hypertension, okay? And then you say, I would prescribe this and this and this based on that. And then we gave also the clinicians and we saw how they prescribe. Do you know that AI can actually help you choose the medication, choose what tests to do, and then tell them how often they should come and what tests they would do. So now we are saying, if, say, Mugumo Health Center cannot get access to Dr. Ngugi, then what they can do is ask AI, can you assist me? So AI is both good and bad. you need to be able to interpret. So they used us, the experts, to then look and predict and see, did AI give the right information? And that's some of the studies we're going to be talking about in the conference. How are we using AI? Let's not be left behind by technology, but can we be able to control its use so that people, one, don't abuse? We don't want a scenario where a patient goes, puts in their information, and then AI tells them what to do. There's a way a doctor can interpret, and you need to input certain things, then AI can tell you what to do, as opposed to if a patient is doing. So what we need to do is educate people on how to better use these tools. And then can it be able to reduce our burden? Yes.
And you saw what even happened in the United States of America when President Donald Trump came in. He cut off US aid. And in terms of many organizations who are depending, tell us if your organizations were depending even on that particular fund. But how have you worked closely with these international bodies, including even the World Health Organization?
Okay, so one of the things World Health Organization does is it provides a lot of funding for the grants, for research, and it's also important for training. Like for a lot of the specialists, let me tell you how our college is functioning. We have no funds as a society. We're doctors who have just come together with one common passion. Then through the Royal College of Physicians, who have trained physicians all along, they said, why don't we give you seed money and start what we have been doing in the UK. Now, through that, they're training. So we're even privileged that the president of the Royal College of Physicians, Mumtaz Patel, is going to be with us in Mombasa to tell us how can we ensure equity in healthcare? How can we provide further training? So we have training opportunities, that is one. Number two, can we learn from them where they began? Like the way their system is run is very different from ours, yet it seems to support that system very well, especially if it is purely government run. We want a scenario where at the end of the day, if you walk into any facility, the care you get in public would be the same from private. So now when we go to WHO, one of the key things is it gives us guidelines. And we tailor our guidelines based on WHO. Provides funding so that we can be able to do research. Anytime a new molecule comes, you realize Africans are not included in that particular cohort. And some of the things the patients ask us is, are you sure it would work in a Kenyan? And we're like, no, but we need funding to be able to conduct that research. And that's why you have institutes like UNITID and CAVI that are now looking at vaccines. You know, it was very instrumental when we had the COVID that we needed to ensure that these vaccines that were given were going to be safe for the population. And that's where WHO comes in. When President Trump, you know, withdrew, there was a panic. I can tell you for a fact, one of the problems we have is when you're so used to donations, you don't look to see how you would sustain it if there was no funding. And that's something that we've learned. Why don't you receive the funds, see how it is run? Let me give an example. We have Novo Nordisk Foundation. What they do is they provide free insulin, free monitors under the Changing Diabetes in Childhood program. It covers for type 1 diabetes up to the age of 25. You come to the clinic, you're tested, you're educated, you're screened, and you're given your medication. Okay? Now, the question is, when you get to 25, who helps you pay? You're so used to getting things for free, then what happens then now when you have to pay? And that is where now some of our control gets lost because we can't afford. And so what we are saying is we go back to the drawing board and we ask Ministry of Health. We ask Treasury, listen, this is the data we have. WHO helped us get this grant funding. We've got the research that shows we need to refocus more on NCDs now. Can you increase that budget? Okay? And then provide this medication at a subsidized cost or even free. If someone can pay for SHA, then they get the medication for free. And that's how we work. But one of the things we need to learn as Kenya is we stop being dependent on donors. We need the donors. Let's get this straight. Through that, we can be able to generate the data and we can present these international conferences so that when we are talking about the trends of diseases, Africa is on the map. We need to stop saying we don't have data. That's why when you have these colleges, I want to know, is diabetes different in Kisumu as opposed to in Nairobi or in Mombasa? Are we experiencing the same problems, and how are we tackling it? If we see a certain surge in cancers, particular cancers coming from a particular community, then I can tell the government, can you redirect these efforts so that now we train these people and we figure out, is it the soil? Is it the pesticides we're using? So that we go back to the drawing board. Like, let me tell you one of the things we learned when we did a research in Kibera, and we found that up to 60% of the children were obese. That means this 60% will be adults we have to take care of, isn't it? So you go back and you tell Ministry of Health with Ministry of Education, if you open a school, you have to have a playing field beside. Children have to have time where there's physical education.
Yes.
Then you go and you talk to Ministry of Agriculture. How are foods being provided? How are foods being generated? How are you planting? What pesticides are you using? What herbicides? And then is there GMO? Isn't there? And then you go to KEBS and you say, you find that the labels are misleading. Let's change the food labeling. You understand? But where is this coming from? Us technocrats, the technical experts. We work with them to drive change. So we got the funding, and the funding showed us the problem, okay? And they also give us medication. I remember what they gave us the vaccines for free.
Yes.
If we did not receive vaccines, we were looking at the number of deaths were going to be at the point where we could not have managed. And that is why, in as much as we are still seeing COVID, there's a problem. That brings me to the vaccines. We've got guidelines for vaccines. Do you know who is supposed to be vaccinated in this country? You believe it's only children, right? Do you know that majority of people die because of simple influenza?
Yes.
And I say, if you have a chronic disease, so we go back to NCDs. If you have diabetes, hypertension, chronic kidney disease, cancer, you have a schedule of pneumonia vaccine, flu vaccine, hepatitis vaccine. That's what we are talking about. Then we go, and if we invite the minister and he hears that there's a problem, there's a gap, why aren't our elderly patients being given the vaccines? And we say there's no funds. And we can't keep asking donors to give us free vaccines. Can we then manufacture our own vaccines? That is how we are influencing. Yes.
Okay. Aside from financing, given that there are numerous challenges that you do face as physicians at the end of the day, so what are these challenges that you're set to address in that particular conference?
Okay, one of the things is we've started a college. It's Eastern Central Southern Africa College of Physicians. But we have no funds to run the college. We call it the College Without Borders. You see, if you have University of Nairobi, you know the funding comes from government. If you have Aga Khan University Hospital, it comes from Aga Khan Education Board and all. And where does EXACOP get the funds? And this is where government comes in and we say, we are training physicians to take care of the population. Can you give us funds to help run the college? Okay? Then we are training these physicians. And we tell them this is the ideal, this is the standards we want. That I'm not going to train a specialist, then you put him in Mandera and you can't even check a random blood sugar. And so that's a problem. There's a mismatch. We are training, but the facilities that are there are just not equipped. You find in certain counties, they go and they put up CT scans and MRIs, or they put up even an ICU. But where are the doctors to run it? Where are the nurses? And so our pain points are, we train, but then the doctor is not able to utilize their skills adequately. And so you find someone leaving the country. Because do you know that Kenyans are, the reason why we are so popular out there is we're the best trained. And so we have the knowledge, but we can't practice. So what we say is we go back to the drawing board. And that is why we are saying, let's boost. Now, if you find Joe TRH has capacities, they have enough patients, but say they don't have the capacity to train about oncology, then come to KU and we'll train. But imagine this doctor is trained how to manage cancer, then goes to Thika Level 5 hospital And there's no chemotherapy. There are no even tests to do a blood sugar, a hemogram, a full blood count, or a kidney function test. Is he going to utilize? And that is where rubber hits the road. That the society then recognizes the need for capacity building, for training, for research. Can the government meet us halfway? Can we ensure that all our facilities are equipped so that we can provide the necessary care? Okay? Then when it comes to the cost of education, it's quite expensive. An average student will pay for a master's 700,000. Okay? Now we've started a college where they're not paying fees, but we train them. Now us as consultants, as we are working, we are training on the job. But I need to be paid, I need to be compensated. So I'm part of the training committee for EXACOP. And one of the things the consultant says, compensation for time. You pay teachers, you pay lecturers. We are lecturers, but we don't get paid. So you see, we need funding for our college. And that is why our appeal is, if we have the Minister of Health or PS of Medical Services coming for our conference, they'll understand where the pain points are. We need to enhance our facilities.
Have you invited them?
Yes, definitely. We are hoping that Adandwale and Oluga will show up so that they can actually come. You know, we're excited. It's our first graduation. where we'll be having 15 students from the region, but 9 are from Kenya. So for the past 4 years, we have trained painstakingly these students. I mean, the college has been there for 10 years, but our first batch is there. And I'd like the minister to sit in front of these graduates and tell them, you know what, if you want to go and work in Mombasa, okay, and you have a cardiac patient, we know we'll give you the facilities you can be able to treat. A patient doesn't need to leave Mombasa to come to Nairobi for specialized care. We provide the specialists, you provide the facilities. We're very excited that, and we are hoping that, I know he's out of the country, but we are hoping he'll make it in time, especially on the 28th for the graduation, so that he can give us some assurances. We train, now give us the chance to treat Kenyans the way that they should.
Okay.
Yes.
Given that we're entering the final leg of our conversation, but what are the key takeaways we expect out of that particular conference at the end of the day, once it's concluded? It's
awareness. What are we doing in each of our, you know, we're talking about, so we are training, so what we want to see is, what's our capacity building initiative? Are we training enough people? Can we increase capacity? And that's why I invite people from the Medical Council and then also CUE and the ministry. Then number 2 is, are there enough opportunities for research? We need funds to be able to generate research. Let's see what's been done. Let's see how we can collaborate, because we're having collaborators from the UK and from the US coming in to talk to us about what is it that they have in store for us. Then at the same time, we look at what we have done this far, what we could do better. We've got guidelines. Are they getting to the people who need it at the end of the day? So we need more capacity with education. And I think for a long time, the ministries work separate. What we're saying is, if we got a chance to work with Ministry of Education and Ministry of Health, can we incorporate some of these things in the KMTCs and the universities and the colleges to improve in terms of the knowledge, okay? And then look at all the specialties that are there. You know, you'd be surprised at how many specialists are out there that the average Kenyan does not know. So one, raise awareness of where our pain points are. And here our focus is NCDs, NCDs, NCDs. You look at someone, are they likely to be looking at diabetes, hypertension, kidney disease, heart failure, so that then we go back to the drawing board and say, let's work together in a technical working group, come up with what it is that is our ask. Then we go back to government and say, we need this. Funds are released, we work together. So this conference, one, will showcase our college that we are very proud of. Okay? We call it the College Without Borders because we are assuring you, as Kenya Association of Physicians, you know, it's our 28th annual conference. But for the first time, we are showcasing our graduates who are out there, and we are saying, these are people from Mombasa, from Nairobi, from Eldoret. You have new specialists. So you don't have to come looking for them in the main towns, like in Nairobi or Mombasa. You understand? Yes. Another key thing is, who are we collaborating with? who are our partners and how can we strengthen these collaborations. You know, I get a student being trained by someone from Zambia, Zimbabwe, Malawi, okay? Through that, someone says, I like this opportunity, goes to 3 months in the UK, comes back and says, I got these ideas on how we can change the outlook. Let me give you an example. In KU, about 3 months ago, we started an NCD clinic, and we said, instead of treating just diabetes and hypertension, combine them together. It reduces the cost, and you can actually ensure someone does not spend the whole day in hospital, but we cover for everything, and we take care of the patient holistically. Isn't that a better thing? Now, if this is a pilot project, then let it go and extend to all other counties. So we are sharing ideas. This is the only time physicians can come together and know what is diabetes doing, what is cardiology, what is oncology, because that one physician is the specialist for all the patients there. And when he's not able to, then you can send to the specialist. So we are educating our physicians and then giving them, throwing down the gauntlet. We give you the challenge. Go and do your work on the ground. Do your research, tell us your pain points, and then we redirect it to make noise where appropriate, so that our voices are heard. And at the end of the day, you know, it's ensuring that we have a healthy country, healthy people.
Thank you for reminding me. There's a question I forgot to ask you. In terms of physician, the ratio between a physician and a patient, if you have those figures, kindly give us.
Yes.
Okay.
So ideally, according to WHO, for every doctor, one should be 10,000. We are only 400 physicians against a population of 52 million. Do I need to say more? I can tell you, and that's only physicians. When you talk about GPs, you're talking about up to 10,000. It means the numbers are just not enough. So what we're saying is, let's try. The GPs cannot be able to become physicians. This is an avenue. Exacop is an avenue. The problem is they could not, they had to leave their families and homes, and that's why Exacop comes in to train. But we need more funding. Ministry of Education needs to give us more funding. People can't afford to specialize. Remember, when you're training to be a specialist, you have your family, you have your bills, and then you have to pay for school. But we don't want you to leave your workplace. This is a homegrown solution. Why shouldn't we use it? And we have support from the Royal College of Physicians, through which we would not even have this. So we are grateful for our funders and collaborators, but now we are saying we need to sustain our college ourselves. Yes.
And maybe finally, before I ask you for your final remarks, talking about in terms of ensuring this is not just a talk show, a talk conference, what measures will you put in place to ensure that whatever the outcomes will come from that particular conference is implemented to the letter?
So the good thing about Kenya Association of Physicians, it's the parent body. And what we have is different societies, specialist societies. Like I'm the president of Kenya Diabetes Study Group. So whatever pain points were noted, whatever take-home messages, then that is what I'm going to ensure I take back to my society. We work on it. We present next year our data on what were the missing things, what did we need to change, and what are the outcomes. Like I'll tell you, we got funding from WHO on a fund, and they're looking at 35 out of 47 counties on screening. Someone will be discussing, this is what we found, this is what we educated them. Then let's go back a year later and let's see what is the outcome of the interventions that we did. So each of the societies will then be tasked that in cardiology we feel too many people come very late. Hypertension, heart failure. What are we doing about it? You come and tell us as a society. So each of them will be tasked with then now working within their groups, okay, to try and implement some of these things. If we say prevention, then they'll ask Dr. Ngugi, how many people did you train last year? Who did you train? What is the outcome of that? Has it shown any benefit in the number of hospital visits has reduced? Number of admissions has reduced? Have we had less amputations? Less people going on to dialysis? So if we work together, then we share this at the next conference, we keep each other accountable. And that's why we have our annual conferences.
And maybe finally, let me accord you just 1 minute to give us your final remarks on what to expect, and of course, going forward, what do you like to see, not only from the government, but other key institutions that you would like to come on board?
So one of the things, I've been organizing this conference for 10 years, and I can tell you, even funding for the conference is actually a problem. And our numbers are growing. So we need support, one, from the government, just to bring these different professionals together so that we can be able to meet. Number two is, we need help in terms of funding for these societies so that we are the ones who produce the data. So we need funding for research. It's very, very important. Then number two is, can we be involved in more meetings which involve healthcare at the very basic level, at decision making, at policy making, so that we can be able to incorporate what we feel is appropriate. But at the end of the day, it's funding, funding, funding.
Okay.
And then we encourage all physicians to attend, because our conference is at Pride in Shanzu, between the 27th to 30th of August. One of the things you do, remember, we're getting delegates from all over the region. So we're also showcasing Mombasa and its beauty. So we're also contributing to tourism. So a little funding never hurt for all of us. But we're very excited, and just know that the physician you see today came and spent a few days in Mombasa, but made a difference in how they're going to manage your condition. So you spare us for the 3 days, but we welcome you to the Kenyan coast, just so that you can experience, one, the beauty of the coast, but understand what we are doing. A lot of the times people are in the dark about all the things behind the scenes. And then if you can have us more often, other than when we're coming for conferences, we are more than happy to give health talks and just talk about what we need to know, what's pertinent about NCDs. I'm very passionate, you can tell, especially with regards to diabetes. But thank you for having me.
Thank you so much. Unfortunately, we have run out of time, but hopefully that particular 1 hour session has been very beneficial for you. That is Dr. Rosaline Ngugi, consultant physician and the president of KDSG, the chair of KAP Nairobi branch. Thank you for making time for us this morning on News Check. I need to pave way for my colleague, that is Khalid Abdullahi, who is currently up next with Kurunzi Mashinani. I'll be back later with the 1 p.m. news. My name is Abdiaziz Hashim. The sign language interpreter at the bottom end of the screen is Lucy Mora. Good morning for now.